So there's the carina.
So that's where we were talking about where the lungs, the airway split off. And so we ventilate the right and the left lung.
You're okay. I'm going into the right lung. The right lung.
So the airways, they truly are like an upside down tree if you think about it, okay? So the further we go down into the airways, the smaller and the more branches that branch off of those bigger airways, okay?
Maybe that's the left side then.
So normally there's that pesky chest wall in the way and we're not able to see the lungs because our patient's all closed up, right? But because these are pig lungs, we can actually see the light going into the different areas of the lung, which makes it easier for us who are
Novice.
not experienced in performing bronchoscopies. We usually get to assist the physician in the bronchoscopy, but we don't usually get to hold the scope. So that bronchoscope, it's flexible, and so the end kind of moves like this, all right? And we're able to move that in order to get into the different regions of the lung, different lobes of the lung and different airways as they branch off. Why would that be important for us to be able to get into the different areas?
Because you might have an infection in one area and not the other.
That's right. So if we want to get into a specific region of the lung because we're trying to look and see either a pathology there, like a tumor or a mucus plug or something like that, then we need to be able to control where that's going, right? Mm-hmm. You want some saline?
Yeah, it would help when we're down in there. Can you squirt saline down in
I
there?
can't squirt saline in that. We can clean the scope, though.
That's all right. I was fine with that.
Can you see that? See how small the little airways get? Each one of those airways is connected to more airways and smaller airways that just continue to branch off until eventually they get to those microscopic air sacs that we were talking about. So my students have been learning about mucus plugging, which would be a partial or total obstruction of some of those tubes. If one of those airways is obstructed, what do you think happens to all the air sacs that are past that tube, that airway?
They blow.
Nope, they get collapsed because there's no air that's actually flowing to those. Okay.
Can everybody get a good view on the screen?
Can y'all see it? So during those therapeutic bronchoscopies, that's what we're looking for. We're going to go in, we're going to clean out that mucus that gets stuck in there, and then those areas of the lung hopefully will re-inflate. Okay. We can also do some things, and Keith brought one for us. There's all kinds of other tools that we can use through the bronchoscope to get diagnostic test results. So if we find something in the lung, we can get a washing, we can send that. Some of those cells will come off when we put the saline down in there, and then we'll suction that out and we'll send it to the lab. Okay? We can also get brushing with a cytology brush, and so we can actually kind of scrape the side of the airway in order to send that to the lab as well. Okay? We also have some tools, they're called Biopsy Forceps. And so what will happen is we take it, it's kind of like pinchers, and we can take it and put it down inside that bronchoscope, and then we'll open it up and we'll actually get on the side of an airway or a tumor, and then we'll close that, kind of like a grabby claw, and then we'll actually pinch off a piece of that, bring it back up, and then we'll send that to the lab, okay? We also have a needle that we can do the same thing with. Okay?
So we're not gonna work with this.
It's
When I
not
was
gonna-
afraid of that.
yeah.
You
Uh-huh.
can pass it
How
around.
far does the ET tube go?
Well, we only want it to go above, where is it, guys, that we want it to go?
5 centimeters above the corona.
Hey,
More question.
we taught them something. Okay, so we want it to be above the carina, right? Because if I'm ventilating the patient with that, then I want that single breath that I put in to go down equally into both lungs. But it happens occasionally that we could actually accidentally put that tube too far and only ventilate one lung, okay? And so we do that on accident, all right? But we have lots of ways to determine where that tube is placed, and so we would correct that really, really quickly. Okay?
What would be a sign that you put it too far?
We'd have what? You guys know the answers to these.
That would be inflating more.
Unilateral chest rise, okay? So it's anatomically easier to put the tube in the right main stem than it is the left because it's straighter. And so what would happen is if we put that tube too far down, we'd only be ventilating the right side, and so that side of the chest would rise much more than the left side. Okay? We'd also only hear breath sounds on the right and not the left. Okay? And then finally we'll be able to see that on chest x-ray. What do you want to say?
I don't have anything to say. You pretty well covered it.
Miss Hicks, do you have something you want to say?
You're doing great. I have a question.
Sure, yes.
Was you put them on 100%? You know how on suction we did the other day, you pushed that 100%? Okay.
A lot of times we will do that. It also kind of depends on how long the bronchoscopy is going to be. But yeah, usually we'll put them on 100%. And then you can see Keith, he's used to doing that job. That's our job, is to make any kind of adjustments to the ventilator and then also hit the silence button, because we've been talking about airway resistance and compliance. So what happens to the airway resistance now that we have this big bronchoscope down in the tube? It greatly increases the airway resistance, right? And so we're going to get all kinds of alarms on our ventilator because now we're trying to breathe around that bronchoscopy, or around the bronchoscope itself, okay? What other questions do y'all have? Anything? No? Y'all?
What happens to the bottom of the lungs, or how do the lungs, how are they different when someone has pneumonia?
Oh, that's a good question. Y'all want to answer the question? When somebody has pneumonia?
You're good, Jose?
Any kind of consolidation in the lung can be caused by fluid or blood, or most cases of pneumonia like secretions. So what happens, that mucus plug that we were talking about, it'll go in and it'll actually block off that airway, and then because it's not being ventilated, now that area of those air sacs have collapsed, and so we can't get any ventilation to that area. So while we're talking about pneumonia, we kind of talked about lung cancer. We can talk about maybe the reasons that the doctor would want a bronchoscopy in suspected lung cancer. Y'all know? What would be one of the warning signs that the physician would want a bronchoscopy to check for lung cancer? Okay, maybe they were coughing up blood. That's a good one. Okay. What else?
Labored breathing?
What?
Labored breathing?
Labored breathing. So maybe they've been increasingly more short of breath over the past few months. Okay. That usually doesn't come up all of a sudden, not with lung cancer, but it could with pneumonia. Okay. What else?
I don't think any kind of abnormality on X-ray.
Okay. How about persistent pneumonia? Okay. Recurring pneumonia. What happens is now we've got this big tumor that's not supposed to be there in the airway. And so secretions, just like blood, that snot is gravity dependent, right?
Yeah.
It goes down, right? So it's really easy for those secretions to get past that obstruction in the airway. But then if we have to cough it back up, it's a lot harder because of that obstruction in the airway. Okay? So if somebody has pneumonia over and over and over again, then the doctor's probably going to want to find out why. And when we go in and bronch, a lot of times then we're going to see a tumor in the airway. Okay? And so then we use our biopsy forceps and we get some samples and we'd send those to the lab, okay? Among other things.
I have a kind of a question that relates
Sure.
to our class earlier.
Okay.
You said that when we did CPR that the air could flow into their stomach and make them
Mhm.
vomit,
Yep.
and that they would aspirate it. Would it
Yep.
go down into their bronchial tubes?
Yep. And then that's called what? What do you get from that? Aspiration pneumonia. Okay. But
Oh, like the more you aspirate.
it is much, much harder. I won't say impossible, but it's much, much harder to aspirate once we get this ET tube in because there's a cuff on the end. Have y'all ever seen a Foley catheter?
Yes.
Anybody seen a Foley catheter? It, along with this ET tube, it's got a balloon on the end of it, and that seals off the trachea in this case. Okay? And so by sealing that off, hopefully anything that the patient would throw up would not be able to go down into the lungs.
I see this.
What would you do if they did aspirate the vomit while you were?
Well, we're going to suction it out, okay? We want to get all of it out that we can. But unfortunately, there's a lot of stomach acid and there's a lot of germs that come from aspirating vomit. And so we're going to have to put the patient on antibiotics as well, okay? But we're going to try and suction all of it out that we can get. But we can't ever get it all, okay? Other questions? I totally thought you were going to
I
sleep.
got to watch one the other day.
I thought he was going to last time.
I got to watch one the other day at clinical, and I thought it was pretty cool that they didn't get just one kind of culture. It was two different
Yeah.
kinds. One that was kind of like mucusy and
Mhm.
you know
Slimy?
snotty.
Yeah.
And then the other one was like boogers.
Mhm.
And I thought it was kind of cool because it came.
You had- You had to have
Dried
been
and wet.
Dr.
We'll say
Hubbard.
dried and wet.
Dr. Hubbard will explain the difference to you between boogers, honkers, and something else. I don't know. That was my very first clinical day. He explained to me the difference between all of those. So.
And you're like, oh.
Yes. So if y'all don't have more questions about the bronchoscope, then I'm going to play with the vent and see if we can get the lungs to open up a lot so you can see how big they actually get.